I'm a registered nurse. I'll say it this way: 29 years in the home care, home health space. Everything from being that nurse out in the field to overseeing operations agencies across 8 states. Most of those were skilled. We actually put the ContinuLnk product in across the states that I oversaw. And so I was at the point I decided I was ready to make a change, move off of the provider side. So I came to work for Complia Health and ContinuLnk.
Okay. And Paul, you want to introduce yourself?
Sure. Well, good afternoon. My name is Paul Minton. I am a nurse as well. My title is Senior Vice President of Product Management for Complia, and I am one of the newest members of the team. So I am excited to be a part of this. I'll be mostly listening in the background, but I wanted to at least get on camera and meet you so you could see me virtual face-to-face with the team.
It's nice to meet you too.
Thank you.
So Lindsay,
Both of you.
Yes. And since I'm having a hard time with audio, I'm going to just walk through an initial overview of what we're going to cover. And I'm going to go ahead and turn over the reins to Kathleen so we can get started. The rest of what I was going to present today, I can go over with you on a separate call if that's okay.
Mm-hmm.
Okay. So we just wanted to make sure you're doing about 30% Medicare, 20% Medicaid. You're doing some Medicare Advantage, about 45%, and also private pay. What's most important to you is to have a robust scheduling system. I know it was important for you to make sure you can see that we have the case management and PDGM in place, and you want to walk through that a bit. But you put asterisks on having a strong clinical module. Is that about right?
Absolutely, yes.
Okay, very good. So I'm going to do this, as I say, without further ado. I'm going to go ahead and turn over the reins to Kathleen, and then we'll go ahead and get started. That's okay.
Hey, Lindsay, before we start, I don't have myself showing just because I want to do this. Will you just tell me your role in the organization and your background?
So I actually, my background, I started off as a PT assistant, and I started working with a PT at another agency about 13 years ago. And he started his own agency. This company, Advanced Medical Home Care, is owned by a physical therapist. Okay. And then as the agency was very, very small, I started in on the admin side and did quality assurance. And then I learned OASIS and coding and other admin type stuff. So now I am the head of the QA/QI department.
Awesome. Okay. And you guys aren't just doing PT. I would assume all your payers are doing everything.
We are a full service skilled agency. We do not do like unskilled services. We don't do like PCA services. We do have a handful of private pay patients that do a variety of things. But no, we are skilled services.
All right. Awesome. Okay. So I'm going to focus on skilled today, 100%. And
perfect.
Try to get through everything. But if, sometimes I can go down in the rabbit holes with.
I love those. So.
Okay. And please feel free to interrupt me anytime. So if we're going down those holes and time's running out, we can always schedule additional because you're not in any hurry. I don't think it sounds like you guys want to make sure you're really thorough.
We want to be thorough.
That's
and right now we have more time, and we need, with COVID right now, every single home health agency in the Twin Cities metro area is at capacity and has been for weeks, and it will continue for the foreseeable future. Yeah. So we have to focus our efforts on making sure that our patients are being taken care of first, while kind of working through this to make sure that we're seeing all of the extra flaws in everything we're doing right now, because everything is so big and magnified right now that we need to be sure.
Perfect. Yeah, that makes sense.
So
And
we'll be
I
talking a lot.
okay, that's good. And I also heard that you heard from one of our other agencies. We've actually had a lot of agencies lately reaching out to us from Minnesota. We've got a couple of really big ones there. So
Home
we're
Health
happy to
Inc.
hear.
Home Health
Yeah.
Inc.
Yes.
I think they started it, and
Yeah.
the PT community in Minnesota is very tight knit. We all know each other, especially in home health. And many of us used to work at Home Health Inc. And we heard through the grapevine that they switched to this, and we've heard some nice things from clinicians that are using it, that they like it. So we thought we could. So apparently we aren't the only ones that.
No, you're not. We've had a lot of Minnesota customers reaching out to us, and it's always the best when the clinicians are the ones that are the
they are.
word of mouth. Yep.
They are.
All
So
right. Let's get you going then. So interrupt me anytime. What I'm going to do today is I'm going to talk about everything that your users in the office, your clinical supervisors, your QA people are going to touch. And then I'm going to show you what the clinician on the device sees. So
Perfect.
I'm going to have a method to my madness, because sometimes I think when I flip back and forth, it's a little confusing. So I want to focus just on the back office, and then we'll focus on that clinician in the field.
Perfect.
So the system is cloud-based web browser enabled for the main application. It is user role-based. So basically, we give you 5 roles. You can change those roles. You can add access that doesn't exist in our role. You can say, I don't want to use this role. You have a lot of functionality in how you guys use your roles and create your roles. You can see I have a ton of them in my system. And
so my scheduler wouldn't have the same access that maybe I would.
Correct. We don't do a read only. We basically, if you can see it, you can do it. So I have, for example, a scheduler, one that you can see here, and you can see how this looks so totally different than what my demo does.
Yep.
Because again, your scheduler might not be doing payroll, might not be doing billing, might not be doing anything as far as clinical. You might only give them access to run some reports. So you 100% decide what each role gets to do in the system, and that's what they'll see.
Interesting.
Okay. Yep.
I like it.
Yes. The other thing is, just so you know, that we have started what's called a whiteboard. The whiteboard is basically a workflow. And so by the time you guys would go on the system, most of the workflow will be created for the Medicare. So we're just taking all of the things that we do awesomely right with our system and creating a whiteboard that your user, based on their role, will get notified when there's something that they need to attend to. So, and again, that's role-based. So if I'm your scheduler and I haven't scheduled to my doctor's orders, I'm going to be alerted that I need to add a schedule for the week, because I don't have enough schedules to meet the order that was written. So just know that that's coming, and that'll be available before you guys get here. The system's broken down into process blocks. Each process block is really what you do in that process block. We kind of try to make it really easy for you. So your scheduler is going to live in the scheduler process block. There are video tutorials that sit inside the system. They're 3 to 6 minutes. So if somebody forgets how to do something, I think the finance ones are the biggest ones, because those are the ones that always can cause a little bit of angst. But if you hire somebody new, those videos are available for them to understand how to do something in the process. Additionally, the system is totally customizable to you and your agency. So we're going to talk about a few of those things, because I know some of those things were really on your list of wanting to talk about. So for example, service types is one of those things. What do you want the scheduler to be able to schedule? And then what form would you want attached to that schedule? So for example, if I order a PT visit and I'm going to do that PT visit, I want the therapy visit note to be attached when it's scheduled, and do I want a therapy visit note to be required? So required means if I schedule a PT visit, that form's required, they have to complete the form. They cannot submit the timesheet without the form being completed. And additionally with that, you guys own what questions on the form are required. So that's 100% customizable by you. So most of our agencies that have any kind of volume whatsoever to them say, hey, we want assessments, plans of care coming into QA to be reviewed. But those visit notes, we're going to require the questions. So when the clinician signs and submits it, it goes right to the client chart. It verifies the schedule, but it's also going to make it where you can review them anytime, but it doesn't hold up your payroll and your billing. Just FYI. All right.
So they can't accidentally forget a piece and.
Correct.
Love that.
I know. So I'm going to show you that piece because I think that's what makes us a little bit of a game changer when it comes to skilled, is we've put into the system what we can call our control designer and our forms designer. And this is basically the ability of you to make the form exactly the way you want it. Because let's just be clear, the way you guys want your form to look is not the way Home Health Inc. wants their form to look, is not the way Agency C wants their forms to look. We will not let you change any required CMS elements, and we won't let you remove those from the form. So, but you
per regulation.
Per regulation. But our forms have a lot of clinical content. And I noticed on your discovery that you said sometimes you don't always want those to be check boxes. You 100% control that. So we will teach you how to create your own questions in the system and how you want the clinician to answer that. So once you've got your questions, and we send you a huge library to start with. So there's a huge library. So if I said, I want to see all the controls that you have about eyes, you can search. We're sending you a big library already. You can change our controls, except for the CMS ones, or you can create your own. Super easy. I got a 30-minute training on it. It is a piece of cake to do this. Once you create your questions, or once you create your how you want it to look, the system comes with all the CMS. There's extra forms in here that I've created for agencies to just view, but it comes with all of the pediatric therapies, PT, OT, speech, MSW, all of your required recertification, resumption, OASIS start, transfer, other form, all of those sit in the system. You're then able to take our form, clone it, and add the elements you want to add or remove the elements you want to remove. So you can make the form exactly what you want it to be. You don't have to live with the way our form looks.
Question.
Yep.
So right now with our current system, that is an option. However, because we've now gone from their standard form to a custom form, anytime there's any kind of regulation update, they do zip zero zilch with it.
Yep. So you'll notice, I'm going to come down here. I think I have one down here. Okay. Let me see.
So then I have to buy a whole new form every time there's a change, and we're responsible for making sure that it is what it should be when things change.
Yeah,
we have to buy a whole new one.
No, not with us. No. You don't buy the forms with us. We regulatory keep up with all of those changes. We're going
even our customized ones.
Well, what we do with your customizable ones, if it's customizable and it doesn't have, it's not one of the OASIS forms, we don't mess with that. Your form stays on there. But if, for example, you had a, I thought maybe I had one. if you have, say you take our physical therapy or you take the Oasis and you add your physical therapy elements to it so that your physical therapist can go out and do that Oasis starter care, when the new one comes out, you will see a button on your form that says convert. You just hit convert. It will automatically update your form with the new Oasis required elements and leave your customizable form alone.
Beautiful. So when we switch to Oasis E, we won't have to start from scratch all over again. You guys will.
Correct. You just hit convert and it will convert only those CMS required elements and it will leave the rest of your form alone.
Okay.
Yep. Yeah.
So we don't have to buy a whole new set of customized.
Yeah. You
forms.
Never buy. Yeah. You'll never buy customized forms from us. Those are when we have a regulatory change, we push those out to you, but you can convert any of your forms over with those new elements. All right, good. I'm glad we talked about that because I know that was on your list. The other thing I want to talk about that's on your list, and then we'll start showing you a little bit more of the process, is I noticed that you guys had a lot of angst around your orders and the client-specific documentation. So your library will look different than my library because my library is still the old library. I need to go in and update it. But we spent a lot of time last year doing, with COVID, creating what we call best practice. And so what we said is, for best practice, this is the way it should look. So we have a problem, we have a goal, and we have interventions. But so we've given you a start, but you can 100% change any of these to match exactly what you want it to be. So you can even trigger them to auto-populate based on how they answered the Oasis assessment. And what's beautiful about this, when I get to the clinician's documentation, I'll show you, once they fill out the problems, interventions, and goals on the client on the assessment, it imports into the doctor's order. From the doctor's order, it flows to their visit note. So your clinicians will be documenting exactly to the doctor's order based on the problem, intervention, and goal that was added.
Okay.
Okay. All right. So now let's talk, financial, I've just hit on it to say we walk you through putting all your payments
Financial
in.
is not my department, so I wouldn't even. And even the owner said, you know, don't focus in on that. He said, I'm not even the person to ask about this. He said, once we get to that point, then we'll bring in that person. But he's like, it's not even me.
All right.
So just promise me that it works well, and I'm good with that.
Yeah, it does. And we do have an expert on our side to bring in to talk with that expert on your side. Yep.
Okay. It just so long as it all works within its system and it talks to itself.
Yeah.
And one of our biggest issues right now with that payment is so you can't make your final billing until everything is done. Your orders are signed and returned, and we don't have a way to know that that's done without going in and looking at each and every single thing.
Oh,
so that's an enormous, and then it shows up on the list as ready to be billed. But then you go into the chart and you look through each and every physician's order to see, oh, we added a service, so that physician's order hasn't come back signed yet, so we're not ready.
All right.
And then we've looked.
Yeah,
and now we wait again.
Help you with that. All right.
So that's not a thing.
Yeah, that's huge. No, that's not a thing with us. So
it's a huge waste of time. It's extraordinarily frustrating.
Yeah. Yeah. Okay.
So you have a way to mark it done.
Yeah, exactly. So let's just show you what's in the system. We do have alerts at the top of the system. So you're alerted when you have a therapy visit that needs to be done within that 30 days, but you're going to see on the device, your clinicians know. So it's easy for them to figure it out. Face-to-face, we do eligibility checking based on how often you want that eligibility checking done by payer. We do have a fax and queue. Just a few more things. We have over 400 reports in the system. You're able to run all of them.
We love reports.
Yep, CSV, Excel, and PDF. But we're really going towards trying to, instead of you having to run reports, everything being on the whiteboard so that you're not looking for your errors. They're just right there in front of you. You can put as many offices, business units on the system as you want. So if you guys, we have it every different way. It's a conversation we have when we roll you out. Some agencies have multiple physical locations to say, hey, I only want one business unit in the system and I'm going to run each one of them as a line of business. Some people say, hey, I have 2 physical locations and I want both of them to be a business unit. You guys decide that, and there's no limit. If you keep growing and expanding, you can put as many business units as you want on the system.
Okay.
Just to click on this real fast, and then we'll start going through. We do your OIG inspection, your OIG exclusion list automatically for you when you put a physician or a new employee into the system. So if they are potentially a match on the OIG, we're going to notify you so that you can go verify it. We also run that report monthly. When the federal government updates their list, you'll get notified that it has been run, so you can verify it. We use the Medispan drug database. So that's how your clinicians are able to add their medications. We do have a feature coming out probably within the next 6 months where there will be the ability to use SureScripts, which means that if your client's found in the pharmacy database, it will automatically pull over the medications into the system for you, for your client. So your clinician's not having to add every single medication. So
we use back office to do that. We get a med list and we have a CMA or HUCs that will do the medication, the baseline medication list.
Yeah, you'll be able to do that. We have a lot of agencies that do that as well, that pre-populate those for the clinician before they ever
then they can make changes on it.
Yeah,
but they don't have to type out all 38 medications.
Yeah, not a problem. You can do that with us. We also do your PCOS and your MPI for your physicians as well. And the system's going to notify you if you have a non-PCOS physician on a true Medicare admission so that you can get that fixed. To get the client in the system, we have a quick intake wizard. It is 5 processes we keep up with those admissions for you. So you have the ability to decline a referral. So maybe the client, they're outside the service order. You can make it whatever you want, or you can non-admit them. So you went and they weren't homebound or whatever reason. Pretty much everywhere in the system, there's a drop-down box. You guys get to define what's in that drop-down box. The only time you can is some billing ones. So I've started a client, so let's just kind of go through what's in the quick intake wizard. So we capture when's the date of your referral, where that referral came from, and you only have to have the client's initials. So if a case manager calls you real fast and said, hey, I'm going to be sending this client over, but I'm not sure of a discharge date, you can put them in. They'll stay on the quick intake wizard until you get more information. You attach the physician. Next is demographic information. For Medicare, this is where we check the eligibility right in the system, and it'll return your common working file within 2 to 3 seconds. It might take a little longer, but it'll pop it right.
Our process now is a little more involved in that.
Yeah. This comes with the system and it'll pop up right in this screen. So they'll be able to see right immediately, hey, some other agency already has this client that sits there today.
Does that work like all the time? Like,
yes.
So we've got our on-call staff on weekends, and I get a call on Saturday night from the hospital intake that says, hey, we need to start a care on Monday. I'll fax you over the stuff right now. I can pop all that in here
and hit check Medicare eligibility, and it's going to let you know.
I don't have to wait till Monday morning for my person to come in and do it, because I don't know how to do it.
Yeah, no.
Because they have to do it manually.
No, all they do is hit this button and it goes out and it returns it for you. I can't do it because if I do it, CMS.
Yeah. It's not a real number. Yeah. Don't do that. Don't do that.
But yeah,
but it's a thing and it works. Yeah.
Yeah, and that comes with it. It's through Ability. That's who we have the interface through, but it'll populate right back on the screen for you. So your client's phone number, zone and locations, you can put your client a zone and location or your caregivers, just FYI. We do verify the client address. So as Medicare, supposed to be 2023, I think it'll probably be a couple more years, as they start requiring your caregivers to punch in and punch out, we are already obtaining that information for you. When
I think Minnesota should be, as far as we know, they're starting that in January.
Okay, so you would be set in our system because we are capturing that and we already have the EVV interface. So we would just make sure that that's in place. Okay.
Yeah.
And then
we'll see what actually happens, but it'll be easy to.
It would capture contact information, the client's phone, and then again, episode type, place of service, and client status. Client status, you have a choice of pending or potential. The other ones you can kind of decide. So if you wanted intermittent therapy only, intermittent nursing only, you decide exactly what you want your episode types to be. Pending is that I am going to go out, see that client accepted, and then schedule the additional visits. Potential means, hey, maybe it's a private duty skilled case that you are going to need to see if you can staff it before you accept it. You have the ability to put them in a potential status that will let you schedule out even though the client's not admitted. So you can say, yeah, I can cover this. Let's go ahead and accept it. So potential gives you the ability to do that.
So that's what I'm going to do when I enter it on Saturday from an on-call.
Right. Yes, you can. Exactly. You can leave it as pending too, because if it's a true Medicare, pending probably makes more sense than potential. Potential would be those private duty hourly cases that you really need to confirm you can cover, right? So once you do that and hit accept, it will put a link on the screen so that you can schedule your assessment visits straight from here. You don't have to go to the calendar and schedule them, and you can schedule as many as you want. So based on what schedules you have in the system, you can easily create the schedules right from here. I'm going to show you how you do that from the calendar, but it's there. So the next thing is putting the payer in the system. You can have as many payers in the system as you guys need, but because it will only let me choose episodic because I've put in that episodic to let my let the system know it was episodic. Next is services. You can only choose the services that sit on the client's payer. So again, for some of your Medicare Advantages, if all you can do is skilled nursing and PT, you can't do PTAs. It will never let them schedule a PTA because it will only let them schedule what you put on the payer. And then last is you just come in and admit the client. You can say, I'm going to admit them, add their Q code, and all you do is hit admit, and your client is admitted into the system. So it's super easy to get.
So now you've created so that's the whole intake process. Now you've created a chart for them.
Yep. Now we've started that process. So the next step is just doing that schedule calendar. So I now have my client. Now I can do my schedule. So we have agencies, and you can see it defaults on the client I was working on. But you can search by the client status. You can search by scheduler. So if you're big enough, you have 2 or 3 schedules and they only want to see the clients assigned to them, they can search that way. They can search by discipline. I have way more disciplines than you'll ever have in your system, but you can search by discipline, by payer. So if I only wanted to look at my true Medicare schedules, I can look at those. I can look at schedule status. Who do I have that's still in an open status? That's easy for them to do in the system. So all I have to do is right click on the schedule and say, hey, I'm going to enter a need. And that's going to bring up that same screen that I saw in when I was in the quick intake wizard. So because my services require a doctor's order, and I haven't added any services to the doctor's order, the only thing I can schedule now is the assessment. So it's going to make sure that you do that assessment.
Mhm.
Anything that's visit, which is going to be most of what you do not have to put times in and times out. Those will be created on the schedule when your clinicians go do the visits. So,
okay. Yeah, so we can't add a time
you can
to the
add a time.
schedule.
You can add a time. If you
Okay.
don't add a time, hold on, let me do this. Let me put my caregiver in there. If you don't add a time, when your clinician gets to the home and leaves the home and they put their time in and time out, it comes over and populates the schedule for you.
Okay.
So that's an automatic thing that happens with us. Because most
But
of
it's
the time
after the visit is opened.
Yeah. Because most of the time when you're talking about skilled services, I'm the night before trying to figure out which order I'm going to see my clients in, right? But you can put time.
Our therapy takes care of their own. They manage their own schedules. They'll say, the PT will call the PTA when they're at the house and say, all right, PTA, can you see them on Thursday? PTA says, yep, I got time at 3:30. So then we put it on the patient's calendar in the house and PTA puts it on their own schedule. We have to use Outlook because our schedule is so crap. But so this works perfect for therapy for that.
Yes.
But nursing, we do it all for them.
That's fine. You still can.
We tell them, okay, nurse A, you're going to go see, Mrs. Smith at 8 a.m. You're going to go see Mr. Walter at 9:30. And you're going to go see this person at 2.
Yep.
So can we enter their schedule in the calendar and say 9 o'clock, 8 o'clock?
Yep. You 100% can enter their time.
Okay.
You just are not required to on a visit service, but you absolutely can. Does that make sense?
Yep.
So for what you need, it's going to work both ways. So see, I easily added my time. And you'll notice I already have a alert that's showing up that's telling me, hey, you've got this client, but you haven't put the principal diagnosis in. On the schedule, there's a cue that you guys, color index, you guys will use this and look at this for about 2 pay periods, and then you'll never look at it again. So it's going to let you know if it's out of auth, if it's out of orders, there's no principal diagnosis, the visit's been complete, the documentation's attached, it's verified. The schedule is everything. So on those Medicare Advantages where you have authorizations, it's going to let you know, I'm going to reset this, it's going to let you know when you've got visits that don't have auth to cover them. You can
we say, hey, you only have auth for 6 PT visits. You can only schedule 6 PT visits.
You can even turn on hard stop. So if you want to hard stop them from being able to schedule without an authorization, you can turn that on the individual payer, and it won't let them schedule additional visits until they put the auth in the system.
Okay. So you won't even let them open it.
It won't.
We were just hoping for some kind of warning.
Well, you get
this is better.
Yeah, you get the warning, but so this system is so the best. Before I went on the system with the schedule, I was trying to manage so much on Excel spreadsheets. I had one Medicare Advantage contract that I had that I could not use LPNs. I can't even tell you how many visits I paid an employee that I had to write off because they were forever scheduling our LPNs. It won't let you do that. It won't let you.
We love hard stops. Just dummy proof. You can't mess it up. We love hard stops.
Had Kentucky Medicaid where the nurse could go out and do the assessment, but until Medicaid gave you an authorization, you could not do any other visits. We were forever writing those off. Once you turn on the hard stop on that, it won't let them do it without that authorization. So
what about if you have, or do you get a warning if you've only got one left?
Yeah, I'm going to show you that next. I'll show you how it looks on the schedule, and you can run reports. So there's a report that's called an unbilled reason report that will show you everything you haven't billed. Once you process payroll, there's a schedule issues report that you could run that'll show you all of your out of office, no primary. So it's basically saying, hey, if you don't get these cleaned up, they're not going to be billable visits until you fix them. If you do payroll, it'll pay the employee, but it's not going to bill it until you put the auth in the system. When you put the auth in the system, it auto releases that claim for you, and you can run the unbilled release, and it's going to let you know, hey, all of these visits released and paid, because now you put the authorization in the system. So the system keeps up with all of that for you. You don't have to manage it.
Kathleen,
What about if you're running out of orders?
Sorry.
Same thing.
Yeah.
Same thing. You can do hard stuff.
Go ahead. I'm sorry.
You can do hard stop orders as well. And the system also will notify them. And I'm going to show you in just a second. It's going to show you on the calendar that you don't have orders to cover visits. A visit that you don't have an order for, it will still allow them to do the visit, but it's not going to be a billable visit until your clinician gets the order in to cover that visit. Unless you write hard stop. If you write hard stop, it'll never let them schedule it.
Yeah, we just have every once in a while where we do, we're seeing them every single day for 2 weeks, and then every 3 days, and then we didn't know what after that. So we didn't make any more orders, and then somebody forgets to make new orders, and because now we didn't know, do we need to go every other day, or are we going down to twice a week?
Yeah, so
and somebody forgot.
Yeah, let me show you on the schedule what that looks like. So when you have a visit that is scheduled that doesn't have an order to cover it, you automatically see it on the schedule that it's out of orders. If you have a visit that doesn't have an authorization, it's going to automatically let you know it's out of authorization. So you guys know every single time when there's a problem. There's no guessing. It's all right there for you, right?
Yep.
And really,
so what is this schedule view? Is this like agency schedule view? Yep.
This is a month view. So if I click on it, it's a lot of clients. I'll tell you my preference to look at it. That's a lot. My preference is, and most of our customers do it in a week view and then group it by client. So when you do it in a week view and group it by client, it's each individual client you're seeing for that week, their schedules on an individual line. So here's Fred Astaire, here's Betty Anderson. Betty needs orders to cover the 2 visits that she's got scheduled. So
there's a lot of different ways to view the schedule, so that like if my nurse calls in at 6 a.m. and I'm the on-call person, so I got to fix these things at 6 a.m. I can just look at her.
Yes, you can go up and just.
Or the client calls and says, I'm not going to be here today. Please cancel all my visits, and then hangs up on you.
Yes. So you can search by caregiver. You can search by client. You can do more than one schedule at a time. So here's my schedule. If I say, hey, I'm going to fix these together, I can go in and edit the time. I can cancel both of them. So if my caregiver called off, I can cancel them. If you cancel them by caregiver, it moves the schedules into an open shift. So hey, these schedules I need to get covered, and then you can assign a new caregiver to them. You can cancel it by client, and you choose the reason that it was canceled. If you need to do the missed visit note from the schedule, you can, but your clinicians can also do it on their device as well.
You can start a missed visit on there from that?
Yes.
Oh, I love that.
Yeah. Yep. Okay, so let me just go back and show you. I want to show you just a client that's got everything. So as your clinicians do their visit, I'm going to go to month view. So as they do their visit and they complete their documentation, it's going to put the time in and time out of that visit on the schedule. It's going to partially verify it. I think I have to go back one more month. It will partially verify it if you haven't attached the visit note. Once the visit, you haven't QA'd it. Once it's QA'd, it's a verified visit and it's ready for payroll and billing. So again, the schedule lets you know everything. It's super easy. On the schedule, you're going to be able to tell really fast what visits haven't been completed. You can easily know what's going on with your client. You can drop and drag a visit from one calendar day to the next calendar day. You can hold down the cursor and change multiple schedules at one time. So if you need to edit the time of multiple visits, you can do that as well.
So if our scheduler or we get our orders for PT twice a week for 3 weeks, and we
Yes.
want to enter a generic twice a week for 3 weeks, what does
Yep.
that look like? And let them
So-
pick their times.
Yep. So you just come in and you say, hey, we're going to do a PT visit. And you can do the easiest way is you can say, hey, this is going to repeat on Tuesday and Thursday for 3 weeks. Or if you want to pick the dates, you can come in and say, hey, it's going to be Wednesday and Friday for 3 weeks. So you have the ability to create that schedule out as far as you want it. The other thing is that we also have what's called a schedule queue, and the schedule queue lets you know when you've created an order that your schedule doesn't match the order. So if you're over, you're always going to see that on the system. But what about being under? So my scheduler on Susie Auth was supposed to schedule 2 visits. She only scheduled 1. So I need to get that additional visit in. You just click on this and it'll take you right to the calendar and you can add that visit right there.
Okay.
All right. So let's go. All right. So lots of things you can do in the schedule. The schedule tells you everything, right? So it makes it super easy. So once you've got your visit scheduled and it's completed, let's just talk about how that works in the main application when your clinicians finish their paperwork. So when they finish their paperwork, you have the ability to view their forms that are ready now to be approved. Those sit in the QA for you. You can, if you have teams, you can have a team. So if you have more than one clinical supervisor and more than one QA person, and you want to assign which nurses that QA person's reviewing, you can do it that way as well, whichever way works for you guys. With multiple ways you can look at this. But when their visits come in, if it's a visit that is a required visit, you'll see that there's not a trash can. That means you can't delete it, they can't delete it. You said on the start of care, the OASIS had to be completed, so it has to be completed. But if you have forms that you say or you put on the visit but aren't required, those forms can be deleted. So they didn't complete the risk assessment, or they did and you want to delete it, then you have the ability to delete those.
So if they open the wrong form, they accidentally open too many, they opened too many of something.
Yes, you 100%.
They opened a missed visit, they started a missed visit, but then they got to go back 2 hours later.
Yes, so you have the ability to kind of control that in Notes QA. Yes.
Okay.
So for the forms, it's pretty simple. You just click on the form. The medication profile sits on every single form, so your clinicians can easily add their medications. They can see their hazardous medications, but you also can add medications right from here if you need to.
Will that generate an order? So let's say we have a home find.
Yes.
Patient has a new, they got a new antibiotic.
Yes.
For a UTI.
Yes. So when they add the medication or you add the medication here in Notes QA, I think this one might have one, it will automatically ask them, do they want to create a revision to the plan of care? If they say okay, it automatically puts the medication on the revision for them. I'm not sure this has one, but that's an automatic process that our system will automatically, I don't have one on there, our system will automatically say, hey, do you want to create a revision? When they say yes, it populates the order for them and it will put that order on there for them. So we don't trust them to do that. We do that automatically for them.
I was like, do we get to review it then to make sure that they didn't?
Yeah. Mm-hmm. Yeah.
Before it gets sent off?
You do. Yes.
Excellent.
Yeah. Orders and OASIS are the two things that I would say to an agency, you should never allow that to skip QA. Those should always
never,
right.
ever.
Right.
The only,
right.
we're heavy on the QA side, very
right.
heavy. The
right.
only thing that we auto-complete are our visit notes.
Yep.
And it's not even all of them.
Yep. Well, you can even say by the individual caregiver, We call everybody caregivers. You can say by that individual clinician whose notes you want to review, even though you say, hey, we're not going to review the visit note as a whole, but you can say, hey, Kathleen Spooner, we just hired. We want to look at her visit note.
Yep, we want to look at things for a month.
Yep. So you can turn it on and all of her stuff will come into QA. When you're finished with her, you just turn that setting off and her notes will start going to QA. Bypassing. Okay. So a couple things I want to say on this that you have the ability to do. You can see mine says get new signature. Let me talk about a few things. If it's a start of care, it's going to, there won't be any outcome. So you'll see that, but if it's a recert, and I'll show you some of this when we get to it, it will let them know outcomes and it will let them know as they answer it. So if they're answering and they'll be able to see, hey, this client is stable, they improved, or they declined on those important CMS quality
So
things.
I won't, what does it do it on all of them? Like one of my biggest pet peeves is if I see a start of care and a recert and a recert and a recert and M1200 vision goes back and forth and back and forth and back and forth. And I'm like, really, is their vision that unstable, or are you really just not doing this right?
Yeah, so there's a few things we do with that. So
but that's not an outcome measure.
It's not, but they see that.
But it drives me crazy.
It does. Yeah, so they see that on, there's a cog on every form. So how I'm looking at it in QA is exactly how the clinician sees it on their device. Okay. So when I click on that clog, let me get one that's down here that makes sense. So when I click on that clog and I view control history, it's going to give you how that question was answered every single time. So if I go to something like vital signs, all they have to do is click view control history. And the view control history is going to show them, hey, this is what it's been. And this client, I don't have much on, but it's going to show them, hey, for the last 3 months, this is their vital signs. For the last 3 months, this is their weight. For the last 3 months, this is their wound. And this was their wound measurements. And this is every single question, including any that you would ask, are going to give you that ability to see that information. So
once the start of care is done.
Yep. Once they save a form, it automatically starts creating the control history.
And it'll pull data from multiple sources.
Yes. Whatever control, it pulls it from, if this control sits on 5 different forms, it's going to pull it from all 5 of those forms in that time period for you to view.
For example, the vital signs, like you'll see everybody who's done it.
Correct.
So if we have vitals from PT, OT, speech, and 2 nursing visits.
Correct. So they don't need to go look in the PT visit note, open it. All they have to do is hit view control history, and it's going to show them how it was answered. Yes.
Okay. And how far back does it go?
It defaults to 90
or
days.
Rather, how many entries are there? Because like vitals,
it could be any.
In a week, they could have 10.
It'll go for 90 days, however many they have in those 90 days. So
okie dokie.
Yeah, but they can change it. If they only want to look at the last week, I don't want to look at, we took it 90 days only to make sure it went past a recert period. So if you needed to see a prior, but if I'm a clinician in the home, when it comes to vital signs, I really only want to see what's been going on this last week. They can change.
Yeah, you want to see the, you want to see the weights for.
Correct. So they have the ability to see that. So this is the outcome assessment. So you can see, I can see my client declined. When they answer this question on the OASIS, it will highlight it in red and let them know it's declined. So it really does let them know right away, hey, is this truly?
Did I really mean this?
Yes. Did I really mean that? Yes. So
I don't have to go back and ask them later. Just double checking.
Correct.
Because you wrote over here that it wasn't, so.
Correct. So in QA, you have the ability to approve the form. You can edit the form. You guys choose which questions you edit. That if you edit their answer, it sends it back to them for them to sign off on. That was that get new signature. So I changed a question that required it to go back to the clinician to sign off on it. So
and we get to pick which ones?
Yes, you get to pick which ones. Yep. You also in QA can approve the form. You can reject the form. So rejecting means it just puts it back in progress. So if you say, hey, I started reviewing this and this is so bad, I'm not.
I need you to start over.
I need you to start over. When you click in progress, it basically shows back up on the clinician's device that they can then just go in and start working on it. So the important thing to know is when you start the QA process in our system, the clinician in the field cannot pull that form back. You 100% own that form in the system. So they don't have the ability to pull it back unless you send it back to them or you put it, you reject it, that puts it back into progress.
Okay, so question on that. One of the ways that we currently look at our did you leave?
No, I'm here.
Oh, okay. I just got a message across my screen that said Kathleen Spooner left.
Oh,
sorry.
I logged in the first time and my login disappeared and the screen disappeared. So I think it was that one. Go ahead.
Okay. So one of the ways that we measure our clinicians' accuracy is we have two functions. One would be like they have a couple of things on their OASIS that were wrong. Their vision declined, but it didn't really decline. And I'm like, no, you wrote over here that it was fine. This is wrong. You answered it wrong. I'm going to send this back to you for correction. Now, we can run reports that tell them, hey, you have, all of your OASIS end up back to you for correction. Versus we have another function. So I get the OASIS in and I code it and I'll QA it. And if it's good, then it's called a push. So I get to push it back to them to say, review the codes, make sure you like it. This is your assessment. And then adjust the symptom control ratings. Yes. But it doesn't need any correction. So it doesn't count as to be corrected, but they still get to see it again and sign off on those changes that were made.
Yes. So
and it totally separates them.
Yes. So how we do that is if you change, so that would be one of the things when you come down to your diagnosis, home care diagnosis and severity. So when you guys code those diagnoses and you add that or you leave those blank, when you send it back to them, it highlights it and lets them know. You can also, if I can add comments to the caregivers, so I can say, please add.
Please review and adjust severity ratings.
Yes. So when you save that, it will add a little notepad that lets them know, hey, you've added a comment to this section. You need to review that. And so the important thing with that is that it highlights for them and it creates a different version. So you can see my nurse did it. And now I'm the admin person and I did it. So now when it goes back to the clinician, if she makes changes, it's going to come back to you. It's going to be version 3. So
if she says, no way, this isn't right,
Yes. Okay. When you totally complete it and you approve it, then those comments are hidden from the printed record that exist in the consolidated patient chart. So your surveyor is never going to see these comments. So it allows that really good communication back and forth. You can see because I added it and added the comments, it's now saying get new signature, and your clinician will be able to see on the device that is sitting there waiting for them to review. So they can easily find that.
Just go
you
in
do have the ability to roll it back. So if you put that and then you realize, oh man, I put that on the wrong one, you can roll it back. You can pop it out. So if you guys are on 2 screens, you can pop it out. It's one continuous printed like version. So that instead of going section by section, you can easily review and go to the section that you need to make a correction on.
Okay. How does it look for them when I make notes for them to so you just showed me a note for the coding.
Yeah, it'll look,
now, am I just going to make one big, huge, long note about all the things that are wrong, or are they go in individual sections or pages?
I'd go in and look at those individual, they will have it on each one, and they can go show only changed questions, and it's going to populate what you changed or what you made comments on.
Okay.
So
I don't usually change anything.
Yeah.
Like I'll change M2200, but they don't care about that one.
Yeah.
So I'm not.
Yeah, but if you had comments, they just click show only changed, and it's going to pull them up and show them all the questions.
All the comments.
That you need.
So you make comments on each question, not even on each section?
You can do it. You really want to do it by the questions particular that you want them to answer and fix.
I'm so in love with this.
Yeah. I'm glad.
I have happy tears right now.
So the one other thing I want to show you, when you go to hit approve, this happens on the device as well as it happens in QA. So I'm showing you a lot of what the device is going to look like.
Okay.
They first get their errors. So if they've created an
this
error,
ran through the scrubber.
yes, it automatically goes to the scrubber. If they have an error, say they marked the one that always comes up is those GG, those new ones where they have inconsistency. If they have an error, they have to go fix the error. They cannot sign and submit it with those errors.
Okay, so are these errors true errors that is up to date CMS guidance? So every year every quarter when the Q&As come out, like initially the wheelchair item, they said, we don't want you to answer based on transport wheelchairs for the GGs. Then 9 months later, they said, actually, we do. So then it went from an error to not an error.
Right. So,
and our current scrubber did not update any of that.
Yes. So we use OCS. The reason we use OCS over the others is that OCS is instantaneous. So we want your clinician to have that information right away. We don't want them to have
up to date guidance.
Yeah. So OCS updates these validation errors, and that's where we get it from. So we're not maintaining it. We're getting it from our OCS.
Okay. Yep. Gotcha.
After the errors, they then get the warnings, and you will see those again in QA when you're QAing it just like they do. So it's already saying.
So it's things that may be inconsistent, but sometimes patients are inconsistent.
Right. So you might want to review them, but they can overwrite it. And when they overwrite it, they can then submit it. But you will see those as well. It takes electronic password in QA and on the device to approve or sign and submit any form. So it's going to automatically put who approved this form on the form. So you can see it's now approved and signed. And it will fall off. So this is Sharon Lewis. When I go and hit search, it will then fall off of my QA. So my QA is only going to keep up.
Okay. So what if my, so that Oasis, the clinician did it, they sent it into the office, I coded it, I QA'd it, all looks good. I want them to adjust those severity ratings. So I send it back to them.
Yep. If they do what you say and there's they don't make any other changes to it, when they sign and submit it, it's going to go straight to the consolidated patient chart. It's not going to come back to you. If they make a change on the form, then it's going to create a new version and it's going to send it back to you in QA to review.
So if they do their severity ratings only, I don't even have to see it again?
Correct. Yep.
That's amazing.
Yep. We try to make this easy. Easy, but right. Okay. All right, so next is orders dashboard. So you've approved the orders in QA. If you have somebody who's then keeping up with the orders that need to be faxed out, you have the ability to see what's ready to send, what are all your incomplete orders that you have that you need to get completed, that there's a problem with, what you've sent and you have not gotten back. We do have a faxing dashboard in the system. It is not just for orders. You have the ability in our system to send any fax out of the system. I'm going to have to go up pretty further. You can send any fax in this, any paper that you have in the system. So you have an assessment you want to send to the doctor, you can fax it out of our system. You say what gets faxed, what doesn't, miss visit notes. All you do is say, hey, I'm going to send this fax. You hit send fax. It auto-populates with the fax number of the physician. You can choose to send it to all of the physicians. I don't know that I have additional physicians on this client, but if you have 4 physicians and you want to fax it to all of them, you can.
Our total need patients that we want to send to the ortho and the primary.
Correct. Yep. Once the fax comes back, this is what I will say. Let me go back out a little bit of time so I can get this as well. When the faxes come back, it's going to notify you. If it's a fax that did not come from our system, doesn't have a QR code, and we weren't expecting it, it's going to come, hold on, let me just do this. Let me go map fax. I think this is like an H&P paper I just created in here. You will then just come in and name the client document, choose what kind of document it is and map it, and it'll go to the client consolidated patient chart. Right today, orders come back into the pending because, again, we currently cannot read the fax. The fax machine can't read it to say, hey, yes, this doctor signed this fax.
Oh, yeah.
Yep. So you want to put
did they sign it and date it, and it's not cut off too much?
Right.
Yeah.
So you have the ability to then map it. Once you map it, you can unmap it if you mapped it to the wrong chart. Anything you discard will sit in the fax and queue for 30 days, and then we delete it because we always just have that little bit of angst that maybe you discarded something you really didn't mean to. Node 2 is going to be at the point before too much longer, who we do the integration with, that they will actually be able to read that the physician signed it and dated it. And so when that happens, they will auto map for you. But up until that point, they do go into the pending. Okay, a few more things. We're getting there. The client Oasis homepage, you have the ability to lock client. I'm going to go in and pull up a new client. You on the Oasis homepage lock the client's assessments, but it's where you have the ability to manage and see all of your assessments and those assessments that have been accepted by CMS that you needed to send, and the ones that came back that were not accepted, they were rejected. You can run a report that'll tell you all your rejected OASISes, but the system will update when you upload the validation report. The system updates every single OASIS to let you know was it accepted or not accepted. We do have the ability to create the OASIS submission file for you. So every OASIS that you locked that's now ready to be submitted, you just hit generate the OASIS file, and it's going to populate. I probably don't have any in here because I haven't locked any, but it's pretty easy. It'll create the validation report for you that you can upload it. Now let me show you something that's going to blow your socks off, and then we'll run through what it looks like for the clinician. In our system is what we call the episodic queue. The episodic queue, I will tell you from my agency, I had both my QA and my billers in the episodic queue. So the episodic queue is used to say, and you can see I have a lot of old stuff in here, ignore that, but it's used to say, hey, these are the episodes that you have that are the wraps are ready, or the EOEs are ready to bill. It's really a billing tool because it lets you know, hey, all of these things have been completed. Now it's ready to bill. For your Medicare, we auto bill at 10 and 4 every single day. So you don't have to go in and bill them. If you have all green checks and you've said, hey, if it's got green checks, it can bill, we're going to bill it for you. You cannot just come in and check what is wrong. You have to go fix the problem. So on this one, there's a verbal order to the start of care date hasn't been completed. So if I click on that link, it's going to take me to that verbal order that I need to fix. So you will always know what's going on with all of your your Medicare billing. And notice of admission is going to let you know. So Robert Johnson is another admission that I've done today. It's going to let you know, hey, here's the clients that you have started care, that you've started the Oasis or that you've admitted. And it's going to let you know. So you have to admit them, you have to have started the Oasis, and you have to put in a verbal order date. You then, the system's going to automatically send those notice of admission wraps for you.
Those no pay wrap.
Yep. And if it gets to where it's starting to be day 4 or 5, it's going to let you know, hey, you better get on this, or you're going to have a problem that we're going to, Medicare's going to recoup. So and we allow you on your Medicare payer to choose the HIPS codes that you want these notice of admissions to bill. To do that initial no pay wrap, we true it up at the EOE when you've truly done.
With the actual HIPS code, but we can throw a dummy code in if we need to. Correct.
Yes. Yep. The other thing is we have a lot of PDGM reporting in the system for you. I think one of the most important ones is the PDGM managing visits report. This is going to let you know for your 2 billing periods what your LUPA threshold is. It stays 0 up until the point you've approved and locked that Oasis, but it's going to let you know, here's your threshold, here's how many visits you have scheduled, so that you guys can really kind of manage those LUPAs.
But this is only after the Oasis is done. So we can't look at that ahead of time.
You can look at it ahead of time. It's already looking for me right now. It's just not going to give me my LUPA threshold, right? So it's already saying, hey, this is how many visits you have scheduled. So this one down here, I have 18 visits I've put on this schedule, but my Oasis isn't locked, so it's not going to throw in my LUPA threshold until I get that locked. But it's already saying you got 18 visits. This is kind of what it's looking like so far. And here's my HIPS code, here's my projected. So it kind of gives you all that information. It's just not going to put that LUPA in for you till the Oasis is locked.
Yep, gotcha.
All right. Okay. So I think that's a lot of clinical for the back office. Let me just show you.
Can you just quickly show me what my QA thing is going to look like? Like, I'm ready to go in, I'm starting my day, and I want to look at all the starter cares. I want to make sure that I get those starter cares done first.
So you can go, if all I want to do is starter cares, I can go to advanced search and I can say, hey, I want to look at all of my starter cares and hit search. And it's going to bring up all of the forms that I've got sitting here that I need to complete.
All right.
I can just come in. If I don't want to even narrow it down, I can come in and just say, okay, I want to look at all the forms that are sitting here that I need to go in and get approved and get off of my calendar.
Okay. So I can do both and
do
sort
both.
them by date and.
Yep.
Cool.
So you can sort it by individual client. I'm going to tell you something else that I think is huge for you guys in QA. You have the ability to look at all visits and forms. So if you want to say, hey, I want to look and see what is sitting out on a clinician's device that they haven't started or that's in progress, the system's going to let you know, hey, this nurse hasn't even started her visit note. Let me
have 2 of those.
Yeah. So you have the ability to do it. So you can do it by client, you can do it by caregiver. You have multiple ways that you can search. The other thing is if you have a form that has a conflict, when you approve it, it's going to go into conflict. So this one's telling me I have a billing code mismatch with my therapy. But for example, say you saw a resumption of care and you approved it, not realizing the transfer hadn't been done. It's going to put it into conflict and it's going to tell you that the Oasis are out of order. So once you do the transfer and put it in the system will automatically put them in the correct order for you in the system. So we're not going to let you get out of compliance or forget something. We're going to throw it up and tell you you've got a conflict. You need to fix it. Okay.
Cool.
All right, so now let's see how it looks for the clinicians. So this is what the clinician's login looks like. Currently, it is cloud-based web browser enabled. By the end of third quarter, we are going to have an offline app for visit documentation. So it won't be for them to be an offline 100% because you can't do that validation and everything if they're an offline, but it will allow them to do through an app their visit documentation and assessment documentation for the visit if they're in a disconnected mode. But
if they,
today,
every once in a while, if you have a power outage, connection issue, bad weather.
Yep. So that'll be available.
Patient lives in the middle of nowhere.
Right. So when they log in, this is what they see. So the first thing they're going to see is what's sitting out there in their face that they haven't completed, that they need to get completed. So you can see I am not one of those clinicians you would want at your agency right now. So you do also have the ability to send link mail. You can send messages back and forth to them as well. Hey, I've got a new starter here. There's a team meeting. I need you to complete that visit note and get it to me. So you do have a way of communicating to them as well through link mail. They can click on the form and it's going to take them right to the form that they need to complete. So they don't have to go hunt for it in the client's chart. It'll actually take them there from their homepage. And again, if you had something that needed their signature, it will auto-populate for them so they can see it. For face-to-face, it populates if they're the case manager on a client that you don't have the face-to-face yet. They can't change it. They only see it. So it's just to help you get the face-to-face. Therapy, they see it starts at 0 and counts up so they can see their last visit and when their next visit was due. And it doesn't go away, which is what I like. So they can't just keep forgetting about it. It's right here. You need to get that on the schedule if you haven't. So next they see their schedule for today, and just like it shows on the calendar in the main application, it shows on this for them as well. So they'll know when a visit's out of authorization, when they don't have an order yet for it. So it's super easy for them to ensure that they are doing everything in compliance because, again, everything's on for them. They can Google from where they are to where the client is. They can see their schedule for tomorrow. They can see their schedule for the next 7 days. They can see their schedule for a date range. All of that's available for them. They can see their new referrals. New referrals are anybody that you've assigned to me that I haven't started my assessment. Recerts do auto-populate 10 days before the end of the cert period, but they don't go away until they complete the recert paperwork. So again, it's right there for them. So in case you missed scheduling one, and I'm going to show you how they can easily schedule it themselves, but it's right there for them. If you put anybody on hold, they can see their active clients, and they can also request a chart if you give them access. So if you want them to have the ability to pull up a client that they're going out to see, that maybe they're not the care manager or haven't been scheduled, so my on-call, Frances called, she fell, or she's got a catheter that's leaking, I need to go check on her. They can pull up the chart, document, it falls off their device within 7 days.
Oh, so if they're just, they're just the on-call and they did the one random visit.
Yes, they'll document once they.
We don't have to manually go in and remove them.
Correct. It will auto fall off once they've completed their documentation after 7 days. Yep.
So you can set like a temporary.
Right. Yes.
That's cool.
Yep. Okay, so let's talk about visit and how they manage their visits. So you can give them the ability to edit their schedule. If you do that, basically I can say, hey, I called my client today and he wants my visit moved to tomorrow. They just click OK. It'll move the visit from today to tomorrow, and it'll move it in the main application as well. So you guys will see that they moved the visit. It won't allow them to move the visit outside of the treatment week, just FYI.
Yes.
They also, they also can say, oh, wait, you scheduled this as a nursing visit, but I need to do a recert because now I realize that the schedule doesn't have that recert due, and it should. All they do is click OK. When they click OK, it is going to take the visit paperwork away, and it's going to now replace it with recert paperwork. So it will automatically manage that paperwork for them and ensure they always have what you want them to complete for that visit available at their fingertips.
So what if we've had this happen more than twice, in fact, recently, where a PT will go out with intending to do a 30-day reassessment, just a regular plain old reassessment, and the patient says, I don't want you to come back anymore. We're all done. So then they have to quick change it to an OASIS discharge. They can do that themselves.
Yes.
They don't have to call me and have me make it for them.
Oh,
Okay.
they can do it themselves. The other thing too is you and again, you just put that paperwork on that they're supposed to do. If I started filling this out and then I started filling out my nursing visit note and then I realized, hey, there should have been a recert. As long as they've saved the work they've done, when they come back in here and change it to recert, it will keep the document that they started with the information and add the new one so that they don't lose any information that they would have completed.
It goes to the new form?
Yeah, it doesn't flow to the new form, but it'll keep the form there with the information.
So that they can.
Yes.
Got it. Okay, cool.
Yeah.
That's handy.
Yes, it is. The other thing is if the visit's a missed visit, they just click it's a missed visit. They choose the reason why it's a missed visit. So the client ended up having an MD appointment. It will then remove the visit documentation and it's going to replace it with the missed visit note. So once they've completed that, it will mark the schedule as a missed visit and it populates the missed visit note for you to fax to the physician. Okay. So all of that happens pretty easily for them. So let me just get through a few more things, and we'll be pretty close to done with all the clinicals. So this client, I believe I've already started his OASIS paperwork. I just want to show you how comprehensive the clinical documentation is and why you have the ability. You can see there are a lot of sections on this. And so again, you have the ability to go in and change questions, add questions, remove questions. You can even move the order around. You can say, hey, I want all of these questions grouped together on one page. So there's just a lot of clinical data in here that you have the ability to do and create and make your own. I edited that too fast. One of the things that we've done is we've gone into our OASIS, which I think is why a lot of our clinicians like it, and we've added those elements of the order that on the assessment. So for example, frequency and duration. So if I'm going to write my frequency and duration order, I write it on my assessment, and then I'm going to show you how you just import it into your plan of care. So if I say I'm going to do a skilled nursing visit and it's going to be 2 times a week for 6 weeks, and I'm going to click OK, it auto calculates the end day for me. It's going to auto put in my verbal order date for me. They can edit the verbal order date as they need to. The next piece that's really important is those problems, interventions, and goals that we talked about. So advanced directives is one of those that I had automatically trigger. So I can say, yes, my client has advanced directives. But now I want to go in and add maybe that alteration in cardiovascular status because that applies to my client. And when I look at it, I can say my client has congestive heart failure. Let's see. Okay, this one is the goal that I want him to have. And I can put that date, 6/1/2021. I can put the status of the goal. So I can say 10% met. I can then come down and choose those interactions or those interventions that I'm going to be doing for the client. So I'm going to instruct them on a low sodium diet. I'm only going to choose the ones that are important for me, right? So my client's not on oxygen. I'm going to remove that. When I click OK, I've now created my orders of what I'm going to be doing for my client. So now you can see when I look at it, it's only going to show me what I added for that client. It's not going to show me everything that's available. So I can make it very specific. I can then document that I performed a task. When I do, it also gives your clinicians the history. So if I'm the PT and I want to see all the things that the PTA has been doing, I just come in and click and say, let me see what he's been doing for my client to the doctor.
So they don't have to go back and look at each and every one of those visit notes. But if they said, you know,
yes,
balance exercises.
Right. When they mark something as met, if you research the client, it'll drop off. But when you do the discharge, it will automatically bring those over and say they were met on the discharge for you. You guys don't have to add those. It's an automatic thing that we do for you. So once that's done and I've completed my assessment, the next super easy piece for your clinician is that they just go to that client record. When they get to the client record, all they do on the client record is hit add, build my plan of care, my assessments here. So even in the main application, if you have a nurse and PT and OT, you can import all 3 assessments into that doctor's orders in the main application as well. So if you want to, instead of sending 3 different orders, you want to send 1, you can absolutely do that. So when you hit save, it's going to take what I put on the assessment. It's going to now bring it over to my plan of care. So your clinician just needs to very fastly review it, and it's going to then just sign and submit it. So when I go look at my plan of care, here's what I put on my assessment. When I look at my problems, interventions, and goals, here's what I'm going to put on my, here's exactly what it looks like. Once they save it, it does a validation as well. It's going to do a validation for every single form against what you said was required. So in this form, I didn't fill out the rehab. So if I go to sign and submit, it's going to tell me, oh, I must have. It's going to tell me if I didn't complete something correctly. It's going to show me, hey, you didn't answer these questions. Same with the nurse's note. If I didn't answer the required questions, it's going to tell me, hey, you got to go back and answer these questions. And then just fast show you what the client chart looks like.
Can you show me what a completed plan of care looks like?
Yeah, it's a typical 485. I sure can. Hold on. Let me go back to the main application. Oh, wait, that's not where I wanted to be. Hold on. Let's go back here. All right, so let's go. Let me go to the orders dashboard. That's the easiest place to see it. So let me search. So let's go here. So you can view it in a non-485 way until you get it approved. Once you approve it, it prints it in that 485 view. So let me open that. So it's got that classic 485.
I can't, oh.
Can you see it?
Not yet. Oh, now it's doing something. Not quite there yet. It's running a little slow.
Oh, you know what? For some reason, I don't know why it went off the screen share. Okay, now you should see it.
Oh, we're just back on the screen share.
Yeah,
sorry, we're
able to see it fine.
There it is.
So yeah.
There it is. So it's got that typical 485 look.
You don't see it?
Oh, there it is. Now I do.
Yeah.
Now I do.
Yeah.
Okay.
Yeah. Yeah. So it's going to have your medications. This probably isn't a good one because, again, in demo, I'm not always fit, but it's going to have your medications, your diagnosis.
Yeah.
It has everything. It has your problems, interventions, and goals with your verbal order, date, and time. And you can put the certification statement on there. You can also have it do the face-to-face. So if you have a face-to-face date in the system, it auto prints that on the form for you. If you don't, it prints a blank line so the physician can add the face-to-face for you.
We do not send out a plan of care until the face-to-face is in. So
okay, so there you go.
And we try not to take patients without a face-to-face right now.
Yeah, it's just so much easier. It's so much easier. So one last thing, and I think we'll be finished. This is what it looks like to the clinicians on the client chart. You can see they see the client demographic information. They can add notes that you guys will see in the main application. You can add notes. So if it's lab work on 1025, you can put that in. It highlights in yellow to let them know. They can see the emergency contacts, they can see the client's physicians, they can see the plans of care, they see the frequency and duration. If they want to view the form in a printed, they can see that as well. If you guys have any aides, they can add the paraprofessional assignment sheet. They can add, once they add the schedule, let me get on my client that's got lots of information. Once they add the they can add case communication notes. You can do customized case communication notes. So if you want a COVID, for example, specific case communication note for them to document against that the patient has symptoms or the patient's been exposed, you can add that. So they can easily add a case communication note. You can do a general SBAR or customized one. So you can say, hey, my client's positive for COVID or tested positive.
In the group home, they had residents who tested positive, so
yep.
Heads up.
Yep, so right. And that prints out on a report as well, so you can see that.
Now, are these part of the survey record or not?
Yeah, case communication notes, yes.
Okay.
Yep. The ones you create in the back office don't have to be, you guys choose.
Okay.
Everything's color coded for them. So if I'm working on it, it's orange. If I haven't started it, it's blue. If I've completed it, it's approved, it's green. So it's really easy for them to see.
Visually, this is really nice looking.
Yes, yes. It's really easy for them to see exactly where everything stands. They can see the client schedule. They see it in a calendar view for the CERT period, and they can hover over it to see who's the employee that's doing that visit. They can, they again can see it today, tomorrow, the next 7 days. They also see the medication profile on here. So I'm going to show you that little piece about the medication as soon as all of this catches up. This client's the same one I've documented on for 3 years, and he's kind of getting tired of me documenting. So if I say, I'm going to add a new medication, and let me just say it's going to be ampicillin. Oh, I need to fix that. So anyway, I need to check on that. But basically, once they do it, it populates a message that says, do you want to create an RPOC? They see the interactions. Those automatically populate when they add the medications. They don't have to do anything. They also can see their medication reviews. And it will color code them as well. So if there's a problem, they said the client had a potential problem, it highlights in orange for them. When they do their reviews, it automatically marks the medication profile in the back office is electronically signed by Kathleen Spooner, RN. They can see the diagnosis so that they have their fingers available and have those available. You guys can do supplies if you want. I mean, there's very few that people do supplies on, but you can track supplies if you want to in the system. And you can scan in documents in the back office or make those documents available if you get the faxed H&P and you want the clinician to have access onto it device, they can have it at their fingertips as well.
So like all the documents from the hospital or new patient goes to the wound care clinic, they can have access to these in this section right here?
Yes, correct. Yep, you determine which documents when you upload them or save them in the back office to the client, admission documents that are available on the device, and whatever you save, they have the ability to see on the device.
Okay.
So that's pretty much it from start to finish as far as clinical goes.
So Lindsay, what do you think? I mean, I heard a lot of positive feedback from you so far.
Let's just say that when I go and talk to the boss about this one, it will be very exciting.
Good.
I'm very excited. I love this.
Good to hear.
We did review with Access, and there was a lot of, oh, I don't think that would work for us. Okay, I'll be totally honest. Any areas that I'm like, oh, I'm not quite sure. What would this, like how the workflows would work for us, how we would be able to change these things. I see nothing that's preventing, that's like scaring me in any way, shape, or form. Nothing.
Good. Glad
like this is all very, very, very nice. And I think the hours that I can see being saved, like for so many people, it's a little surprising. Like, kind of makes me feel crappy, like how much time we waste doing some of these things. Like, I feel bad.
Makes us feel
Like, oh my gosh, I feel bad that we've been wasting so long doing it this way when this could be so easy.
We spent a lot of time to, get this module right. And Kathleen had a big input in making sure that it did what you just demonstrated. We're proud to hear you say that. And again, it was done trying to make sure that we cover everything that we should, where make it that much more efficient and flow better. So I'm glad you did that. Yeah.
So I'll take this back and talk to other people, and we'll come up with like a list of questions, like, because they'll ask me things that I didn't even consider. Yeah. And I'll come back to you.
Absolutely. Yeah, so just shoot me questions. You and I can get on another call if I need to. I can pull Kathleen into another call to do a Q&A if that's the case. Even if we need, I know there's some other aspects we need to cover in the system, but you can let me know how you want to proceed from that standpoint. And then
yes.
Yeah.
Okay, so one more quick question. When we're creating plan of cares, or when you're creating an evaluation, like sometimes I like to look at, say I've got a newer nurse doing the Oasis Start of Care, and a really experienced PT just did the PT eval. And these M items aren't looking quite like I think they should be. So I look at the PT eval and I'm like, oh, well, it says they need min assist to walk 20 feet. So you said you put a response of 5 for the GG walk 150 feet. Are you sure about that? So like, is there areas in the PT eval that they document? Like right now we have it set up so they are literally answering those GG style questions with those same answers, with that same scale. Like we had those built into our PT forms just to make it super easy, and across the board everybody's documenting on it the same way.
Yeah, so we absolutely have the ability. We can help you do that when you come onto the system, or we can train you to do that. But yeah, absolutely, we can set up your form to do it exactly the same way.
Okay, cool. And where is homebound documented?
It's on the actual form itself. We have a homebound control, and I'll tell you, most of our agencies make that a required control that's completed every single visit that they do, right?
Yes, absolutely. No, we have to, in an ADR, not homebound, that is the stupidest way to be losing money.
Yep. So it actually is a control that sits on all of our forms, visit notes, and everything.
Is it just check boxes, or are you really required to like write something in there?
It's check boxes, but based on let me see if I can find
those specific CMS examples.
Yes. But if it's one of those that it's dyspneic walking, and it'll populate a box for them to put in how much they are walking before they get dyspneic. So it depends.
So they've got little.
Yes. And if you want it to, again, you kind of control that. So if you want them to have the ability to have to put in more specific, you can. So this one, when I check it, see how because it's rest after so many feet, it's telling me how many feet are you saying? Is it 50?
Gotcha.
Is it 10? So it populates a box so that they can then choose it.
Okay.
If I chose other, it's going to populate a box.
Okay. So, does your system integrate with, does it communicate, does it talk to another external software called Worldview?
Not that I'm aware of, but again, if that's
what is that, Lindsay? Worldview. I think you mentioned
it is something. It's one of those external where you can like take pictures of things, wounds, prescriptions, and just automatically get uploaded and attached to the patient chart. So like all of our due to COVID, we switched all of our like admission paperwork to paper, and the patient signs it and it stays in the house. We take photos of it. We do a photo scan of these admission documents with their service plans and all of that stuff, and then we upload it to the chart. So this would be a system that automatically used that photo from our Adobe scan or whatever on the phone or on the computer, and would automatically upload it to the chart direct from the patient's house, instead of the nurses, the admission nurses sending it into our CMAs and then the CMAs saving it to the chart. Like, this just does it.
We don't currently today, but it's something that we could check on for you if we could do that interface.
Yeah.
Because I know that we're looking at integrating that into what we currently use very soon, and it would be really nice if it traveled.
Right.
Yeah,
so, Lizzie,
definitely we'll check on that for you. Now, just know that we do have a prescription one that's coming, sugar scripts, that'll automatically update your medications. But yeah, let us check on that for you.
Okay. So in this case, how would you currently, where would our admission documents look? Where would they be in the chart now? In that little, in the bottom right-hand corner, those?
Yeah, they're there for the main application, I mean, for the clinician, but in the back office, the consolidated patient chart sits in the main application. So your true client record, they can see information, but you have the ability to see all of it. So you can see, here's my face sheet, here's all the admission documents. So you can see some of them aren't sitting on my device because maybe I didn't want to put them on my device.
Yeah, it was
garbage. It's going to give you your drug information, your etiquette. So this is a lot. You can also do by cert period. So this is the client that I told you I've got going on. So if I just want to see the documents related to that one cert period, I can see them.
Okay.
So, and you can, we would say in our system, we prefer you not get the surveyor access, but if you did, you only give them access to the consolidated patient chart. But you can create a PDF print job that you can then put on a thumb drive and hand to your surveyor, so they have all the information from the chart that they would need.
Mm-hmm.
Yeah.
Okay.
Right. Okay. So Lindsay, just so I understand your process a little better, and I know you said you're going through an extensive vetting process, but in regards to ContinuLnk and related to us, what are the next steps that I need to be mindful for and look to work with you on?
The next step right now would, I'm going to take all of this information back, and everybody's going to say, what about this? What about that? What about this? What about that? Things I didn't even think of. And then we'll come back and do this again. Then the timeline on that right now is not enormously tight because we have a lot going on right now, and I don't have endless time to, be doing this. So we really want to drill down and look at very thoroughly each and every process that right now is A, giving us a huge headache, B, looking at how that would change our workflows and deciding how much work is it going to be for us to make these, to make a switch, to make a change. And that'll determine the timeline. Like, is it something that could be done this year? I don't know. I'll be honest, the way that this year has been so far, we're going to have to say no, because we just keep getting busier and busier and busier. While I know that our current process, this meeting today has really emphasized how much time we waste on a bunch of crap. Mm-hmm. So that could bring some urgency to this, like, okay, we could take that energy and put it elsewhere. But we said initially that we wanted to look at least 3 different systems. You guys are the second one, but we have looked at WellSky, and this beats out WellSky by a lot. Like, I'm over it. I don't even want to talk to them again. we don't even have another system in mind to think about looking at right now.
Okay.
But we told ourselves after we got scared with access that we had to look at 3 of them. That was what we said we had to do.
Okay. Well, if it would,
but we want to talk about it to the biller and see what their big problems are to see if this, saves time and money and things like that. So really, I'm going to go in and I'm going to talk to them, talk to people from our different departments to see what do they need? What do they want? What do they wish for?
mm-hmm.
And then come back to you for basically another one of these for a question list.
Sure. Okay, we can certainly do that, and I'll follow up with you just to check in to see what your timing looks like for the next step, call Q&A, or even another demo for your billing side. I mean, you can certainly see that, on the efficiency side of things, ContinuLnk has it there. It can help save you.
It really does.
Yeah, and with that time comes, savings, right, on revenue.
Yes, it does.
So that, I think, would
wasting my time is expensive.
Yeah, and I'm sure that would get Mike's attention as well. So
it will.
If it would help, I can send you the recording of this demo, right? So that way you can look back on it, because I recorded this. So I figured,
oh, cool.
Since you
okay.
time that you were looking at, working through some things, and this would be good to have a refresher. So I'll send you, and then you and I can keep in touch about what are the Q&A, and then the next time you want to get together and meet to discuss. All right.
Yeah, let's. I've got a couple of people out of town on vacation the rest of this week. So we'll be able to touch base next week to come up with, what everybody wants to know towards the end of next week. So I'm thinking maybe schedule something the week after. What is that?
The week of May, what is that? The 10th. Maybe
10th-ish, yeah.
Okay.
Yeah, does that sound good?
Absolutely.
Yeah, my QA partner she's in Florida right now. We've got several of the people in the office work from home for some quarantine time right now. So, things are a little busy right now, but yeah, I'm very excited to bring this.
Good.
Bring this one.
So I will follow up with you with an email and highlight a few things. I'll also include a link for this recording, and then we'll nail down another date the week of the 10th. Okay.
Perfect.
Right. Very
perfect.
Good. Thank you, Lindsay. It's been a pleasure.
It was so nice to meet all of you. Kathleen, thank you so much. I really appreciate all of it. I love it. Thank you.
You're more than welcome. Have a great
rest
of the day.
Bye, guys.
Bye-bye.
Have a good day.
Thanks, Paul. All right.